is that in a sense it's a symptom. It means the patient is arteriopathic. It means they have disease in their arteries already. Indeed, people with intermittent claudication are 3 times more likely to die in any given time period than people that are matched for age and sex. If you like, it's already a symptom. So we need to be aware that this patient is probably going to be generally arteriopathic. Maybe the next thing to mention is that prevention is always easier than cure. The problem is when people are young and fit and healthy, they think they're going to live forever. Of course they're not. And the lifestyle factors are probably a major component in the etiology of the disease. But the lifestyle factors that cause the disease are in a sense also the lifestyle factors that tend to perpetuate the disease. So it's worth addressing these lifestyle factors before a person develops disease as a prevention, and indeed after the person's developed the disease, to stop the disease from progressing. And the first one that's well worth mentioning is smoking. Smoking contributes towards the process of atherosclerosis. Smoking makes the patient excrete more vitamin C, and smoking also increases the amount of carboxyhemoglobin in the blood. So some patients with peripheral limb disease, if they stop smoking, that will increase the oxygen carrying capacity of the blood, and that can improve their symptoms quite considerably. So in peripheral vascular disease, as in virtually any disease, there is always an advantage in stopping smoking, even if the disease is already established. The next lifestyle factor is exercise. Exercise will help to prevent the condition from occurring, but once the condition's occurred, exercise will also slow down the advance of the condition. Now this is something I've only learnt myself recently, but each tissue controls its own perfusion. So when a tissue has a high metabolic demand, more blood supply will go to that tissue. So if someone exercises, they increase the metabolic demand of their leg muscles, then over time that will increase the vascularity supplying blood to the leg muscle. So exercise is a major advantage. It will also help keep the patient generally fit, which is always a good thing. Another obvious lifestyle factor is diet. These patients want to eat less fat and sugar, and they should eat more fresh fruit and vegetables. This will also increase the amount of fibre in the diet. If they eat plenty of fruit and vegetables, they'll be getting plenty of vitamins, particularly vitamins A, C and E, and they'll also be getting flavonoids. And these help to mop up the nasty, damaging free radicals that develop inside cells as a result of metabolism. If you mop up the free radicals, you'll improve the health of the cells. If you improve the health of the cells, then you'll improve the health of the tissue itself. Diet is also a factor, of course, in preventing obesity. Obese people can't get around as well, so they can't exercise as well. Some people say it's a good idea to cut down on caffeine. But 2 factors which are definitely important in ischemic limb disease. One is keeping the limb warm, and the other is keeping the limb low. Now if the limb is warm, this will tend to cause a peripheral vasodilation. That will increase the blood supply and can to some extent alleviate the symptoms. The other is keeping it low. So if you're getting pain from your foot because it's ischemic, then the pain's likely to be worse when you lift the foot up, and the pain is likely to be relieved somewhat when the foot goes down, because you get the gravity assist factor in the perfusion of the periphery. So quite a few lifestyle factors there to think about, preventing peripheral vascular disease, and indeed even if there is established peripheral vascular disease. Now there's 3 particular conditions which predispose to the development of peripheral vascular disease, and indeed arterial disease in general. The first is hypertension, so this should be prevented if possible. If it already exists, it should be recognised and it should be treated. So all these patients should definitely be screened for hypertension. Another obvious one is hyperlipidemia. Again, these patients should be screened for hyperlipidemia, partly because, as we've already mentioned, they should be screened for other lifestyle factors which are going to predispose them to coronary heart disease. And a very major factor in the development of peripheral vascular disease is diabetes mellitus. Not so much the diabetes mellitus, but when the diabetes mellitus is poorly managed. So we should be aiming to keep these patients' sugars as low as possible without the patients becoming hypoglycemic. Let's think now about some interventions that could be carried out. Well, I think the first thing to mention is that these limbs must never ever be compressed. The patient should not wear tight stockings, they should not have tight bandages on their legs, because this will further reduce the circulation to the periphery. This is especially true of the ulcers, because in venous ulcers, if it's caused by venous pathology, the aim is to compress. But in arterial ulcers, it's absolutely vital not to compress the limb. That is absolutely contraindicated. What about aspirin? Some people advocate using aspirin to reduce the likelihood of thromboembolic complications occurring. Probably relatively low doses, 75 to 300 milligram kind of range daily. This is probably beneficial. Patients that can't take aspirin, well, there's lots of other alternatives that you could consider. Now, pain can be a factor. Ischemia causes pain, and the best way to relieve the pain is to relieve the ischemia, is to try and maximise the perfusion that the patient's limb is getting via the mechanisms we've already talked about. But if pain is a feature, and this is true especially in acute conditions, then we can treat that sometimes with opiates, sometimes with non-steroidal anti-inflammatory drugs. And these patients should certainly consult a chiropodist. A chiropodist should be involved in seeing the patient. Now, if all these things fail, we might need to resort to surgical interventions. A few years ago, sympathectomies used to be quite common, but these don't seem to be used as much anymore. In a sympathectomy, the sympathetic nerves, which, remember, the sympathetic nervous system constricts the peripheral vascular system. The sympathetic nerves were killed in some way or another, but this isn't done very commonly now. Intraluminal techniques such as angioplasty are a possibility, inflating balloons inside the vessels to dilate, to compress the atheromatous tissue. There's quite a few bypass type techniques can be used, femoral popliteal bypasses, stents, various types of using veins to bypass vascular areas. And vascular surgeons will sometimes do this if there's proven localized pathology. The investigations of where you actually inject dye into the arterial system to illuminate the arteries, as we saw before, that can be done, but should only really be reserved for patients that are likely to get specific surgical interventions. Finally, of course, if everything else fails, necrosis is developing as we saw in that clip before, then amputation may become necessary as a last resort. Now, one problem after amputation is phantom pain, and the amount of phantom pain seems to be reduced if you can control the pain well prior to the surgery. So if a patient is being admitted for amputation, pay special control to analgesia, to pain relief before the surgery, in the hope that we will reduce the likelihood of phantom pain after the surgery. So amputation, unfortunately, sometimes necessary as a last resort.
Now, just before we leave the discussion of peripheral vascular disease, I want to talk about one more aspect, and that is acute limb ischemia. This can occur in arms, it can occur in legs. Actually, I've never seen it occur in an arm, but it can. It certainly occurs in legs. So let's think about the clinical features now of acute limb ischemia, a limb ischemia which starts abruptly, all of a sudden. Now this is usually superimposed on chronic limb ischemia. So if you're working with patients with chronic limb ischemia, it's especially important that you know about this and are able to recognise it quickly should it occur. And there are actually 6 P's that we can use to learn the clinical features of acute limb ischemia. The first one is P for pain. Whenever a tissue is becoming ischemic, usually there's pain. Now, actually, if there's a very abrupt, complete limb ischemia, there might not be much pain present at all. But normally there's pain. And if you squeeze the calf muscle, that's normally quite painful. It's an indication of muscle infarction. So pain is the first P. The second P is pallor. The limb goes white and pale. The occlusion itself will cut off the blood supply, but distal to the occlusion you get profound arterial spasming. So the limb goes white. After a while though, an hour or so, after a few hours anyway, it'll start to go mottled as you get deoxygenated, stagnant blood near the surface of the limb, dark blue mottled appearance. So pain, pallor. The third P is pulseless. There won't be any pulses distal to the occlusion. That is reasonably obvious. The fourth P is paralysis. The limb won't be able to move. Remember, the peripheral nerves depend on oxygen. Nervous tissue is very oxygen dependent, and when the limb starts to become hypoxic, the peripheral motor nerves will no longer function and you'll get paralysis. So the patient won't be able to wiggle their toes. So pain, pallor, pulseless, paralysis. The next one is paresthesia, which can lead on to anaesthesia. Now I know this is a slight contradiction with the pain, but there is normally a developing loss of sensation. And again, the sensory nerves in the limb require oxygen to function. And when they become hypoxic, they'll no longer function, so the paresthesia can develop into an anaesthesia. It might just start with a loss of light touch sensation on the dorsum of the foot, but then progress. So pain, pallor, pulseless, paralysis, paresthesia. Now the last one is actually a bit of a cheat. It stands for, the P is for perishing cold. It means the limb goes cold. Now this can be a bit misleading if you're working in hot climates, on a hot ward or on a hot day, because actually when the limb is cut off from its blood supply, it will adopt the ambient temperature. So if the ambient temperature is fairly warm, the limb might not feel that cold. The limb will take up ambient temperature. So pain, pallor, pulseless, paralysis, paresthesia, perishing cold.
Now let's think about the etiology of acute limb ischemia. Well, the most common, maybe 60% of cases, are caused by thrombosis secondary to pre-existing atheroma. As we looked at earlier on, a clot forms in one of the arterial vessels. Probably the next most common cause is emboli from somewhere. The most common site, of course, is the left atria, often complicating atrial fibrillation. So thrombosis and embolism. Now trauma is another possible cause. For example, it can complicate fracture of the tibia in adults, and it can complicate a supracondylar fracture of the humerus in children. Can also complicate dislocations, and indeed it can complicate blunt trauma. So it's always worth assessing pulses distal to an injury. Doesn't do any harm, so anytime the limb is injured, feel free to palpate the pulses distal to it to make sure there is no limb ischemia associated with the trauma. Now the next one I want to mention is an iatrogenic cause. Remember, iatros means doctor literally, iatrogenic means that which begins or is caused by some kind of treatment. And this can happen if there is accidental intra-arterial drug administration. So if you mean to give a drug into a vein and by mistake somehow you manage to give it into an artery, and it does happen, then regardless of what that drug is, if you inject it directly into a peripheral artery, it's going to cause profound peripheral vasoconstricting arterial spasm. The arteries that you inject the drug into will spasm down and close down, and you can get a profound peripheral ischemia. It can result in amputation, very severe. So whenever you're giving intravenous drugs, you should be able to guarantee that it's going into a vein and not an artery. So intra-arterial drugs, profound arterial vasoconstriction and limb-threatening ischemia. I think the last one I mentioned in etiology is aortic dissection. If there's a dissecting aortic aneurysm, that can cause acute ischemia of the legs.
Let's think now about the management of acute limb ischemia. Hopefully you've been fairly on the ball and you've spotted it early, because this is a surgical emergency. There is only a few hours to save the limb. Any tissue deprived of its blood supply for any period of time, the tissue will simply die. If it's an elastic band wrapped around a child's finger, unless you get that elastic band off, the finger is going to die. Tissues need a constant blood supply. This is a surgical emergency. Now, it may be that the patient needs an angiography to see where the blockage is. But this will only work if there's an incomplete blockage, because if there's a complete blockage of the blood, then the dye, of course, gets into the limb in the bloodstream. And if the blood's not getting into the limb, then the radio-opaque dye will not get into the limb either, and you'll be no better off. Apart from that, if there's a complete obstruction, if there's a complete ischemia, if essentially the leg is infarcted, you haven't got time for that. It is such a surgical emergency. So angiography normally only used if it's an incomplete ischemia. The patient would normally be given an IV bolus dose of heparin. This will do two things. First of all, it should prevent the clot from getting any bigger, assuming it's the thrombosis which has caused the condition. It should stop the clot getting bigger. And the second thing it will do, if there are collaterals which are still carrying blood, it will protect those collaterals. So IV bolus dose of heparin, preventing extension and protecting any collateral circulation which is still patent. Now these patients need the immediate attention of a vascular surgeon for surgical revascularization. This could be embolectomy or thrombectomy, removal of the embolus or removal of the clot, normally by opening up the artery, passing a catheter in and pulling out the clots with a balloon on the catheter. So emergency preoperative care, very much the order of the day. Now, I've no experience of this personally, but thrombolysis is sometimes used in this situation, and I've heard recently that directly administered thrombolysis is a new experimental treatment. Thrombolysis, of course, remember, will actually break up the clot. It will break up the thrombosis, whereas the heparin will not. It will just prevent the clot from getting any bigger. So thrombolysis, perhaps a treatment to look out for in the future. Now, the very last area I want to talk about in terms of acute limb ischemia are reperfusion effects. Now, when a tissue is cut off from its blood supply, obviously there's going to be changes in that tissue, and then when the blood supply gets back into that tissue, if there's a reperfusion of the tissue as a result of treatment, then that can have effects, and again we need to look out for these effects. And we can divide these into local effects and systemic effects. Locally, there might be some impaired muscle function, but because there's increased capillary permeability in the muscles, then there can be swelling in the muscles. So there's increased capillary permeability. A lot of fluid can pass from the blood into the muscle interstitial spaces. Now, can you think of any problems that can occur if you get swelling in a muscle? Well, do you remember that muscles are bound in muscle compartments? They're surrounded by muscle fascia. And that means there's a limit to the amount that the muscle can swell. So when you get swelling in a muscle compartment, it can start compressing the muscle tissue in that compartment. We call this compartment syndrome. It's quite hard to detect, actually. It's very painful, and there's pain when the muscle is stretched. Difficult to detect, but one to be aware of. If there's a disproportionate amount of pain, especially when a muscle is stretched, consider compartment syndrome. It's similar in traumatology. The clinical features are the same and really quite difficult to detect. But it is very important to detect it because compartment syndrome in itself is a surgical emergency and can